So next topic is blood transfusion. Massive blood transfusion. A 56-year-old man is brought into A&E with PR bleed. On examination, you find him pale and confused. The pulse of 140 beats per minute, a blood pressure of 70/30, and a large amount of fresh and clotted blood between his legs. How would you manage him? So I would resuscitate him using ABC protocol for assessment. I would ensure adequate oxygenation, ventilation, insert at least 2 large bore cannulas for venous access, take bloods, routine bloods and coagulative profile and group and cross match. And I would treat profound hypertension initially with crystallite 1 liter, and I will control the hypothermia by covering the patient, giving hard fluid, warm crystallite. And if you are not responding to fluid, I would arrange him blood transfusion. Once established, he needs an emergency upper GI endoscopy, as a torrential bleed from renal ulcer is the most likely source of blood loss here. According to Oakland criteria, his heart rate is 170 and his systolic is 70, so his shock index is more than 2. So according to that protocol, he needs CT angio. If CT angio localize the point of bleeding, it should be embolized or endoscopically secured. If both are failed, then surgery. And if CT angio can't localize, then he needs admission and monitoring, and with blood transfer, and he needs lower GI and upper GI endoscopy on the first available list, and he needs monitoring. His hemoglobin comes back as 60 gram. What blood would you give him? So group specific blood takes 5 to 10 minutes, and cross match takes 30 minutes. So I would initially give him 4 units of fluid, 4 units of group specific blood by fluid warmer, aiming for hemoglobin of more than 7. Blood loss of more than 40% blood volume is immediately life threatening. In this situation, I would give him group negative, group O RH negative blood. In case of extreme blood loss or shortages, and the patients are more than 50, either male or female, then O positive can be given as well. How would you define a massive blood transfusion? So remember the formula: 24, 3 and 1. So if someone's total blood, entire blood volume has been replaced within 24 hours, it's called massive blood transfusion. If someone's half blood is replaced in 3 hours, called massive blood transfusion. Or someone is bleeding about 150 ml per minute, is called massive transfusion. So that's why I said remember the 24, 3 and 1. And British Committee for Standard Hematology arbitrarily defines major hemorrhage as if someone has heart rate more than 110 and systolic blood pressure less than 90. Does your hospital have a protocol for massive blood loss? Yes, it is based on the British Committee for Standard Hematology guidance in the management of major hemorrhage. The main objectives are assessment and resuscitation following Italian's protocol, local control of bleeding, and hemostatic including transfusion products. So assessment and resuscitation, control of bleeding, and hemostatic. So goals are maintenance of blood volume to ensure adequate tissue oxygenation, and control of bleeding by surgical intervention and use of blood and blood component therapies or other pharmacological interventions to stem the bleeding. So I would initiate by conducting the blood transfusion service. Senior members of clinical team like hematologist, anesthetist, theaters and radiologist, and senior ward nurses and portering services immediately for collaboration. Accurate documentation of blood components is necessary for Department of Health legal requirements. What else he needs to be considered during a massive blood transfusion? So there is a risk of coagulopathy. So after 4 units of blood replacement and continuing bleeding, and the patient would need platelets and FFPs. I would prevent this by transfusing the massive blood loss pack, that is 5 units packed red blood cells and 4 units FFPs. I would request a secondary massive blood loss pack which contain 5 units of RBCs, 4 units of FFPs, 1 unit of one pool platelets, and 2 pools cryoprecipitate. The FBC and coagulation samples sent every 5 minutes, 5 units of blood given. Hypothermia needs to be corrected, hypocalcemia needs to be corrected. What is the point of massive blood loss packs? To minimize the length of the time needed to arrange blood products and treat patient in an efficient and timely manner, and to prevent the development of coagulopathy. When do you consider giving platelets, FFP, cryoprecipitate, and prothrombin complex and antifibrinolytics in this scenario? The aim is to keep the platelet count more than 50,000, and if patient is continuously bleeding, then the aim should be more than 100,000. And platelets are stored in the central facility, so their requirement should be anticipated well in advance. Then is the FFP. The FFP should be given as a part of initial resuscitation in major hemorrhage in at least 1 unit to 2 unit ratio with red cells until results from the coagulation monitoring are available. And if the PT and APTT are more than 1.5 times, then also patient needs FFPs at the rate of 15 to 20 ml per kg. And a therapeutic dose of FFP is for 70 kilo adult is 3 to 4 units. Cryoprecipitate are rarely needed except in DIC. The need for cryoprecipitate after 1.5 times blood volume development needs to be anticipated. And cryoprecipitate is a source of fibrinogen. Supplementation should be given if fibrinogen levels fall below 1.5 gram. And cryoprecipitate is the standard source of fibrinogen in the UK. The use of PCC is only recommended in the urgent reversal of effect of the vitamin K antagonist. However, there is currently no good evidence to support. And all patients with major hemorrhage in whom antifibrinolytics are not contraindicated, tranexamic acid should be given as soon as possible at a dose of 1 gram intravenously over 10 minutes, followed by maintenance infusion of 1 gram over 8 hours. The use of a protein is not recommended. Recombinant clotting factor 7A is not recommended. Although there are no comparable studies addressing what are the potential complications of massive blood transfusion. So fluid overload, thrombocytopenia, coagulopathy, hypothermia, tissue oxygenation is ineffective due to reduced levels of 2,3-PG, DPG, hypocalcemia due to citrate, metabolic acidosis due to citrate, hyperkalemia due to potassium leakage from the red blood cells, transfusion-associated lung injury, and then immunomodulation and infection hepatitis B, C, HIV, CMV, cytomegalovirus, and prion disease. What is cell salvage? So this is the process of collecting blood from the surgical field, washing it, then filtering and washing it before it can be transmitted back to the patient. Red blood cells are retained, plasma and platelets are discarded with the washing solution. It can decrease the allogenic transfusion requirement. Cell salvage is appropriate if significant loss is neglected, and it's acceptable to some Jehovah's Witnesses as well. And cell salvage has been used in some type of malignancy urology. There's no any increased risk of recurrence, and previously it can be used in safe bowel surgery or obstetric if it's not contaminated. And cell salvage machines previously used to wash the bank blood prior to its use in case of massive transfusion like liver transplant surgery. The potassium concentration in the packed red cells available from a blood bank increases with the increasing age of the unit of the blood, so it can reach 20 millimoles. So by washing the blood prior to transfusion, the risks of hyperkalemia can be reduced. Thank you.